Thank you organizers for inviting me for this session. And this is not a very complicated thing, it's a very simple thing. So this is just how to approach for get the right antibiotic selection. So Dr. Dilip, if I'm going a bit out of the time, please remind me. Because just to finish off this in another 20-30 minutes is very difficult. So I just tried to put it as a case reports. I mean like case scenarios. So some fever with respiratory symptom. So to begin with, this is a 35-year-old man. It's a non-smoker who comes with cough, and it's something called productive thick sputum. But lungs are clear, chest X-ray is clear, saturation is okay. He just have cough and some low-grade fever. So what will be the best treatment option here? So here, the diagnosis is basically an acute bronchitis. He just have a cough, though it's productive. Otherwise, chest X-ray is normal, your lung is not involved. So acute bronchitis. So what is the drug of choice or how we treat? Are we going to treat with amoxicillin, azithromycin, oral cephalosporin, fluoroquinolones, or are we just going to give some NSAIDs and salbutamol? So here if you look into how are we doing actually is that most of the prescriptions, 11% of total prescriptions goes for acute, antibiotic prescription goes for your acute bronchitis. And not only in India, everywhere. It's basically in UK, US, Netherlands, everywhere, antibiotics are being prescribed for acute bronchitis. But if you look into the causes of bronchitis, that's how we decide what is the right antibiotic. You just look into the syndrome and then see what are all the bugs which can produce this syndrome. For example, if it is a bronchitis, basically it's a viral thing, or sometimes rarely you can have some atypical organisms, or even very, very rarely you can have pertussis, which is almost extinct now. So basically bronchitis is a viral syndrome where we don't need an antibiotic at all if you look from the theoretical standpoint. If you look at the data also, all the randomized trials have not shown any improvement with antibiotics. It doesn't make any difference at all. And the other thing, they have done some studies with procalcitonin, where the initial procal was elevated, they started with antibiotics, and otherwise it was normal, they don't have any antibiotics at all. But from the practical point of view, from ROP, it is not possible to get procalcitonin for all these patients. So it doesn't make any sense at all. It's not very useful tool for a bronchitis. And if you look into the textbooks, simply textbook says that your acute bronchitis only need NSAIDs and inhalers, salbutamol inhalers, so, or just coughs relaxants or something like that. So all we need is an anti-inflammatory, no antibiotics. So antibiotics is not going to help anyway with the acute bronchitis syndrome. So just cough, productive cough, fever, 4-5 days, it's basically a viral syndrome. We're not going with any antibiotics. So the choice there is actually NSAIDs and salbutamol. All the textbooks clearly says that it is NSAIDs. So I'm just put into the second scenario. It's a 56-year-old male with previously good health, has a 4-day history of productive fever, cough, and pleuritic pain. And examination shows a right-sided Krebs, and chest X-ray shows a patch. So this is basically a community-acquired pneumonia. So how we do is look at the pneumonia, divide into community-acquired or hospital-acquired. So outpatient, basically, we expect only a community-acquired pneumonia. And the second question what we ask is, what could be the possible agent which can produce this syndrome? And then only we select for the weapon, which is the best weapon for us. So here, if you look into the causes of pneumonia in outpatient setting, it's basically pneumococcus and then H influenza, and you have atypical agents like chlamydia, mycoplasma, and then respiratory viruses. So basically pneumococcus, H influenza, these are the bugs which can produce in a community-acquired pneumonia. Whereas in a hospital-acquired pneumonia, it can be different. You have all the gram-negative and all those things. So first thing is whether this patient is coming from a community or this is a hospital-acquired pneumonia. And then from community, these are the commonest causes. This I am saying patients who are not immunosuppressed. For example, if someone has a diabetic history or someone has a profuse alcohol abuse, they have risk factors for gram-negative. What is more important is the host. Rather than the syndrome, host is also very important. For example, if the host has diabetes, uncontrolled diabetes, with this thing, could be melioidosis, as we discussed earlier. So it is not just agent. It's not just a syndrome. what is the host? What is the host is also very important. Diabetic host, immunosuppressed host, it's a different platform. I'm saying this is a patient who has no comorbidities. That's where this applies. So in this scenario, what we need to do is that basically pneumonia, if you suspect, you get a chest X-ray and pulse oximetry to try it. No tests except blood cultures, except all these things are not needed at all. If possible, we can get a sputum culture. And we have to decide whether it is a bronchopneumonia or lobar consolidation. As far as lobar consolidation, it's going to be a bacterial game. If it is a bronchopneumonia, it's going to be more like viral atypical kind of stuff. So what does the IDSA guideline says that if the patient is previously healthy, you can use an azithromycin or macrolide for that matter, or doxycycline. If the patient has some comorbidities, you can go ahead with amoxicillin, clavulanic acid, and there's no need of admission if the patient is very stable. You don't need to admit such patients with outpatient community-acquired pneumonia if the patient is very stable. And even you have that severity scoring as well. Now, if your patient has some comorbidities, you can get amoxiclav plus macrolide or a newer generation fluoroquinolone. This is as per IDSA guideline. As per the Infectious Disease Society of America, they say that you can use the fluoroquinolone as this thing. But from the Indian perspective, using fluoroquinolone for a community-acquired pneumonia is very dangerous because it could even be TB. So in Indian scenario, where TB is a possibility, it's always better to avoid newer generation fluoroquinolone because it could also be TB. The issue is that the symptoms get masked. The symptoms get masked, the patient seems to be improving. So it's always better not to use fluoroquinolones for our community-acquired pneumonia, though the Western guidelines say. So this is why I'm always say, it's not just the guidelines. We have to know what is happening around us also. Where are we living? What are all these things? So guidelines are basically comes from the West and all the Western guidelines. We need to extrapolate and look into our scenario, and then we have to filter out from that. And then only we can apply that guideline. That guidelines is basically applied for the Western thing. We have entirely different thing, different set of problems. So we have to interpret that, and then we have to reach to a common sense. That is more important in choosing an antibiotic. So I'm going to the case scenario 2, which is a skin and soft tissue infection. This is a 66-year-old diabetic patient who presents with warm red tender area over his shin and cough. Temperature is 100 degree Fahrenheit. Total count is 10,000. Basically, we are dealing a cellulitis in a diabetic host. So that's where it would be. So what would be the choices here? Cellulitis in a diabetic, what could be the choices? Like ciprofloxacin, amoxiclav, cephalexin, cloxacillin, admit for IV antibiotics. So all those things are there. But I'm telling you, this is a fairly controlled diabetes, not a very uncontrolled diabetes, and the wound is not into the matter of a necrotizing fasciitis or all those things. Just a cellulitis in a patient who just has a diabetes, that's all. So skin and soft tissue infection basically caused by gram-positives. So always we divide into that. Is it a gram-negative syndrome or a gram-positive syndrome? So basically, skin and soft tissue, as far as a normal host is concerned, it is gram-positives only. And here it's beta hemolytic streptococcus or staphylococcus. These are the two commonest agents which produce this one. But if the patient has some comorbidities and all those things, we'll have to consider gram-negative as well, like diabetes and all those things, diabetic foot, all those things. It's not just these things. It could be something else, gram-negative as well. So in a normal scenario, cellulitis is basically caused by streptococcus or staphylococcus. Necrotizing fasciitis basically caused by streptococcus, staphylococcus, and anaerobes. This is how it goes on. So if you have this streptococcus, what will be our choice here? It could be, we can opt from any of these, because all these things works again gram-positives, like cephalexin, cloxacillin, clindamycin, amoxicillin, clavulanic acid. These are all the drugs which we use for the gram-positive. So out of that, most of the drugs can be used for a cellulitis. Preferably, we can use amoxiclav because there is a possibility, being a diabetic, there is a possibility of gram-negative as well, where the amoxiclav can cover gram-negative. So that's how we differentiate. But if the patient is non-diabetic host without any comorbidities, we can even go with the clindamycin or doxycycline. These are all the drugs which is very much effective against the streptococcus and staphylococcus. So it depends, again I'm saying, where is the syndrome, what is the host? That we predict actually what it could be the agent which is producing this one, and then pick the antibiotic based on that. Now this is another scenario where this patient comes with an abscess in the thigh, and this patient comes into our OPD with this culture report. Okay, so you have done an IND, and this patient is coming to our OPD with this culture report. Again happens in the OP. Now we have to pick the right antibiotic from this one. From this culture report, we have to pick the right antibiotic. Already I have started with clindamycin. Now this patient comes with an abscess with this report. Now how will I interpret this report? That's also another thing which happens in the OPD. Now if you look into, first thing, look into the organism, Staph aureus. It was an abscess. Actually it correlates well with the syndrome. So I have no doubt. Suppose if it is Staph hemolyticus or Staph something non-aureus group, right? Saprophyticus, it doesn't fit in with the syndrome. So I will ignore this report because it could be a skin contaminant only. But here it's clean Staph aureus, which actually fits in that. And the first index drug we look into Staph aureus is the oxacillin there. You can see the third one. You have a highlighter? It's not working. So the third one, oxacillin, that actually divides this patient into methicillin sensitive and methicillin resistant. So you know Staph aureus divides into methicillin sensitive and methicillin resistant. But unfortunately, if you look into the culture report, you will not see any methicillin over here. That is a funny part. You will not get the methicillin. The index drug is oxacillin and the cefoxitin screening, which you can see on the upper end. This is the second one. So this was the first one. So if you see the first one, oxacillin is sensitive and the cefoxitin screening is negative, which says that it is a methicillin sensitive Staph aureus. Right? This is how we divide into methicillin sensitive and methicillin resistant. But this is just a simple abscess. If you look here, we don't need to go for all the high funda things. You have your doxys, tetracyclines are sensitive, cotrimoxazole is sensitive. All those things can be used here. We don't need to go for linezolid for this patient. Though it is very sensitive strain, we can get cephalexin done. Right? MSSA, cephalexin will be sensitive. But here you will not get cephalexin reported as such. But we should know that methicillin sensitivity means first and second generation cephalosporins will be sensitive. As a thumb rule, it works. So this is how we decide whether cephalexin is a good drug for it. Look at the methicillin sensitivity or resistant. But if you look into this case, here if you see, the oxacillin is resistant and the cefoxitin screening is positive, which means this is a methicillin resistant. Once this methicillin resistance is there, your first and second generation cephalosporin is not the choice. And for that matter, cephalexin will not be seen in this report. You need to know the fact that if it is methicillin sensitive, you can use cephalexin or cefuroxy, first or second generation cephalosporin. But here if you see, it is cleanly, this is methicillin resistant. So here it doesn't work. Here, this doesn't work. Your cephalexins, all those things doesn't work. So this we label as a methicillin resistant Staph aureus abscess. But again, when I say immediately methicillin resistant Staph aureus, we say that it is going to be linezolid again. But again, look carefully. We don't need linezolid. All we need is, again, you see the same choice. It's cotrimoxazole is there, tetracycline is there. So though it is MSSA or MRSA, my choice is not different. I'm just going to give doxycycline or cotrimoxazole, which is a simple thing. So MRSA not equal to linezolid all the time. We have other options. And then if everything fails, probably we can go for a linezolid. That's how we interpret in our OPD with this one, and always go for the lower spectrum one. Like tetracycline is available, I'll always go for that. If clindamycin, next step I'll go for that. If clindamycin is sensitive, I'll go for that. If everything fails, then the last option only, I'll take the linezolid as my weapon. Otherwise, I'll always go for the lower thing. Now, case scenario 5, this is a urinary tract infection. 27-year-old female presents with dysuria, increased frequency, basically a UTI. Okay. So what will we do here? It's acute cystitis. Now, from the infectious disease point, you don't have something called UTI. You don't have a syndrome called UTI at all. What we have is urethritis, cystitis, pyelonephritis, perinephric abscess, prostatitis. That's how it goes. So one step into the deeper anatomical localization. That's where the whole difference is about medicine and ID. That's all. That's all. Nothing else. So here is basically, we call it as UTI, but from the real perspective, it just fits in as a cystitis. That's all. It's cystitis. So what will we do? Do we start antibiotic, or we take urine cultures, or what are we going to do with the cystitis? A common scenario. Right? So this is where the antibiotic resistance come to play. Now, this is the place, anything below the diaphragm, we are playing with the gram negative. Whereas above the diaphragm, we are playing with skin and soft tissue, and above the diaphragm, basically gram positive game. Now, this is below diaphragm. We have to worry about the resistance issue. Not gram positive, we don't have too much resistance issue, but gram negative, there is a resistance issue, which we need to know. The first thing is, whenever patient comes with a culture, urinary symptoms, always get the culture done. It helps a lot. Not only now, even if this patient gets a subsequent spondylodiscitis or some kind of endocarditis, all those things gives us a clue. So the first and foremost thing, get a urine culture. That's the one thing. And then we can, depending on the local resistance, we can go for either nitrofurantoin, cotrimoxazole, ciprofloxacin, all those things are drug. But the point is that ciprofloxacin has higher resistance pattern. So this, if you read the Western literature, they'll say that you go with fluoroquinolone. But if you look in the real data, it actually 50 to 70% of the time fluoroquinolones will be resistant. So it's not a good drug as such. But what I have seen is that better drug will be nitrofurantoin, which has a favorable resistance profile when compared with the rest. And probably cotrimoxazole comes in between. And third generation cephalosporins in Indian context, actually, though the Western literature says so, because of the high ESBL rates, it is not a good drug as an empirical therapy. Suppose if it is sensitive, we can use once the urine culture is back. Okay. So this culture report, this is a patient, 2 days later comes with this culture report. What is the antibiotic of choice now? Now I started with nitrofurantoin. 2 days down the line, the patient is coming with this culture. This is how OP, basically this is how OP runs. So I'm just running an OP, that's all. So if you look into here, first thing is, this is an OP patient, so I'm not interested in the parenteral thing, so I'm not looking into that. First thing I look at this patient is ceftriaxone. I just look at the ceftriaxone sensitivity. It is resistant. When ceftriaxone is resistant, my third generation cephalosporin knocks out, totally gone. So I can't use my cefixime, I can't use cefpodoxime, all the knocked out, straight away knocked out. First drug which I look into is ceftriaxone. It's gone. Because I want to know whether it is a ESBL producing or non-ESBL pan sensitive. It's not that pan sensitive. Now I will look into non-beta lactam group in this culture report. Non-beta lactam groups, like I'll look at ciprofloxacin. Yes, it's sensitive. Now I'll look into other options like cotrimoxazole, resistant. Nitrofurantoin shows intermediate. So probably with this culture report, I will change from nitrofurantoin, which I had started before, and now put this patient on ciprofloxacin. Because nitrofurantoin is intermediate, it may not work here. Right? But one thing we should remember with nitrofurantoin is that it is used only for lower urinary tract infections in OP basis. It's not a drug of choice for UTI in IP. Because nitrofurantoin basically concentrates in the bladder and the urethral level. There itself. Above that, pyelonephritis, all the IP patients, nitrofurantoin is not at all a good drug. So interpreting this, I will change my choice from nitrofurantoin and put this patient on ciprofloxacin. But the duration will be very short, 3 to 5 days. That's the maximum. Not beyond that, because it's just cystitis. Now, suppose if this patient comes with this report 2 days down the line. Now this is even more complex now. If you see, even the carbapenems are resistant. Now when I say carbapenem resistant, immediately we will be thinking of colistin and all the other thing. But you look at the non-beta lactam group. All these UTIs and all those things, we have to explore the non-beta lactam groups, which is very useful. But unfortunately, you have your ciprofloxacin is resistant, you have trimethoprim, your cotrimoxazole is resistant. Now, your nitrofurantoin is sensitive here. Since this is an OP patient, I will use nitrofurantoin. It's okay. Cystitis only. But suppose this patient has pyelonephritis, this report, I will not go with nitrofurantoin, nor I will go with tigecycline. Tigecycline, you can see it's sensitive. Fancy drug, but poor penetration into the urinary tract. So with this report, if the patient is IP, not into this context, considering this context, I will continue nitrofurantoin for this patient if this culture report is there. Okay, now I'll just go to the next scenario. This is a 79-year-old elderly diabetic female has a urine analysis that shows 10 to 15 WBCs per high power field and performed as part of a lab screen during the workup for a newly diagnosed hypertension. She's absolutely normal, no fever. Just check her urine culture. And the urine culture subsequently grows E. coli. She is completely asymptomatic. Should we need to treat this? Now this is a very common scenario which we get in OP. Now elderly, diabetic, you have the feel that it's an immunosuppressed, so should we treat it? Should we hunt it down? So these are all the questions. So this basically fits in with asymptomatic bacteriuria. It's just an asymptomatic bacteriuria. Patient is asymptomatic. So the fun thing is repeat your urine analysis and culture. Treat only if anatomical abnormalities are there. If there is any anatomical abnormalities, or if there's a neonate, or if you are planning for a urological procedure, that is where you treat the and pregnancy. Very important, pregnancy. These are all the syndromes where we treat an asymptomatic bacteriuria. Otherwise, we will not treat it as a thumb rule. So many patients comes into our OPD with this urine culture saying that my culture is positive, my culture is positive, I've taken lot of drugs. But in spite of that, it's positive over and over. Doctor, get me out of this bug syndrome. Basically, we ask them not to do the culture. That's it. Just stop doing the culture report. You will be fine. Now, that is where the importance of asymptomatic bacteriuria. Basically, don't need to hunt all the bugs what you get in that, especially elderly diabetic females. So these are some of the syndromes which we get in OP, like interpreting the culture report. Now you have to decide on the antibiotic. The foremost thing is urine culture positivity, elderly. They always come with that and say that I have UTI, I have UTI. But you ask carefully, there will not be any urinary symptoms at all. They are just doing repeatedly. Someone would have said that lab worker should have said that this is UTI. That gets into their brain and it's getting into a kind of obsession kind of stuff, and they want to get rid of the bugs. So it's very difficult. So it's very easy as such. But the tricky part is to convince the patient that this doesn't need treatment is the most tricky part. Otherwise, it's very simple thing. So just one slide. Okay. So I'm just going with my last case. This is a fever with GI symptoms, gastrointestinal symptoms. So I have dealt with fever with skin and soft tissues, fever with respiratory, fever with urinary symptoms, a little bit of scenarios. And I'm just going the last thing with a GI syndrome. Now this is a 28-year-old male who has fever for 6 days, abdominal pain, occasional loose stools, no comorbidities, works in Chennai as a software engineer. And next slide. Okay, he has a splenomegaly, normal counts, polymorphs is 58%, RFT is normal, LFT shows by elevated SGPT, SGOTs, with typhoid is positive. This, we are thinking of typhoid, which is a point here. Now next slide. So what will be the best option here? So I have just put it in a question manner, which antibiotic not to use as an empirical regime. Because you know clinical syndrome, you have diagnosed as a Endrick fever now. Because he has all the settings, it fits in with Endrick fever, that's it. Now I'm just taking some blood cultures and then I'm planning to start on any antibiotic. Because till the time comes, I need to start on some antibiotic because it looks like Endrick fever. What could be, what should not I use? I mean, like cefixime is an option, azithromycin is an option, cotrimoxazole, fluoroquinolone, which all can be used and which cannot be used. Now, if you look into this thing, the possibility that this patient could have Endrick is very high. And the possibility that this patient could have, if it is Endrick, the resistance for fluoroquinolones is a little bit high. So I will not use ciprofloxacin as a fluoroquinolone as an empirical regime for this patient in outpatient till I get the cultures. So probably what I can use is azithromycins I can use high dose cefixime, I can use with this thing, or even cotrimoxazole has a favorable resistance pattern as far as this thing concerned, your outcome is concerned. Only thing is that you have to give for prolonged 14 days. And the second thing is when you treat Endrick fever, you have to counsel the patient very well that even if you start the antibiotic, it takes around 7 to 8 days for fever effervescence. So that is the point with the problem with typhoid is that if you don't get the proper diagnosis initially, then once you start the antibiotic, third day, fourth day, the patient will be spiking. Now the patient bystanders will be confused. Now you will be tempted to change antibiotic from one to other. So what is more important as the clinician point is that your pakka diagnosis of Endrick fever done in the early phase, then you can clearly say that even if you start antibiotic, it's going to take 7 to 8 days time for fever effervescence. So that is the point. Otherwise, as a clinician, I have worked as a physician for 8-10 years, so I know how I was shaky with the typhoid. It was a nightmare for me. The patient will not, the fever will still spiking, the bystanders will be asking why the fever, you have started on antibiotic. But the simple thing that take long time. Even ceftriaxone can take up to 7 to 8 days for the fever to settle. So those things we can confidently counsel to the patient initially itself. You get the culture, I mean like your diagnosis of Endrick is strong, just wait for 7 days. But if that is not very strong, probably we will escalate antibiotic, we'll start changing, juggling, all those things happen. So this is one factor we have to know from the clinician point of view when you're dealing with the typhoid cases. So I'm just ending. I've just put a little bit of the scenarios from an outpatient, a little bit of your antibiogram interpretation, and all the, as far as I know, this is how a medicine OP runs. So this is how it will be. So I've just put a little bit of these scenarios. I know I have not completed 100%. It's not possible. So just to give you a glimpse of how, just to learn how we are doing or how we are supposed to do. Understand the syndrome, where exactly, and understand that to the minute level. For example, if you have prostatitis and if you have cystitis and prostatitis, this is actually anatomically very nearby. But if you have cystitis, you are going to treat for 3 days. But if you have prostatitis, you are going to treat for 4 weeks. So there, the duration depends on this exact microanatomy, rather than just saying a urosepsis. For example, you have tracheitis or bronchitis, even if you have Acinetobacter, Pseudomonas, whatever be. It's just 3 days, 4 days. But if you have a pneumonia, it varies from 7 to 14 days. So basically, duration, how long? The answer is, where exactly is the problem? That gives you the clue to what is the duration to be treated. So that microanatomical localization, and then once you get that from the clinical, as a clinician we can get that. You don't need all the investigation. Just to get the clinician we can get that. And once you get that, think what are all the bugs possible for this patient. And there consider the risk factors of the patient. If he is a diabetic, the syndrome totally differs. For example, if the patient is a pneumonia with uncontrolled diabetes, this patient can have Klebsiella, this patient can have Pseudomonas, milioid, anything. Right? It's not the patient. You have two different patients in your OP. One, a 25-year-old man without any comorbidities. The other, a 60-year-old man with uncontrolled diabetes comes with the same pneumonia. You are treating with different empirical antibiotic. That is the difference. So it's not, again I'm saying, it's not the copy-paste of any of these guidelines. We have to consider the host factor. We have to consider the anatomical localization, risk factors for this patient, and then decide on the antibiotic. It's not easy. It's not easy, but it's easy. Once you get that concept, it's like driving. Once you get the concept of driving or swimming, you can easily do that. That's how. So just understand the patient is very important. The host factor is very important before considering the antibiotics. Thank you.
Thank you, doctor, for the really practical and relevant talk. Just one question about the urine analysis. You mentioned WBC counts in the elderly lady example. Sometimes they have a lot of epithelial cells also that are positive in the urine analysis. As an ID physician, do you reject if you see a lot of epithelial cells because it shows contamination?
See, I'll tell you.
So is that a clue there, or do you use that practically?
No, I'll put this way. First thing is, look at the patient, look at the syndrome. If it fits only for the urine routine analysis, then only we'll take into that. Even this patient may have numerous pus cells, right? It will not, I will ignore it many a times if the patient doesn't have symptoms. And likewise, if you have a lot of epithelial cells, it's most likely a contaminant. You will have to repeat the sample. So I will not accept that as a rule. I'll repeat that.
So basically, if there is an epithelial cells in the urine analysis, it's a sample that cannot be used to make a decision.
And it's not a very precious sample or not. You can easily repeat that.
Yes.
So we'll get a repeat sample. So many a times urine, we will have to get the repeat sample.
Thank you so much.
Bye.
So as Shareek sir pointed, while choosing a diagnosis, the first thing should be, what is the host? This host is a diabetic. So he is likely to have a number of organisms, as well as he is likely to develop complications also. Second thing, this patient's syndrome looks like a UTI-like syndrome. From an anatomical point, as sir told, it's a pyelonephritic syndrome, or a cystitic syndrome, or a urethral syndrome. Here, the clinical symptoms are more pointing towards prostate, because he has perineal pain, pain on passing stools and all. So, in this host, a possibility of an abscess to be considered, and the clinical diagnosis put to us prostatic abscess, and a drainage, and PR drainage showed an abscess, and culture showed E. coli. So, next slide. So, the learning point in this case, host is important in making a diagnosis. And the rigor and chills in the evaluation of fever always rule out bacteremia, always rule out syndromic diagnosis like pyelonephritis, malaria in the proper epidemiological setting, and recurrent rigors are most likely to be caused by bacterial infection, and this clue can be used in the evaluation of pyrexia of unknown origin as rheumatological POs, rigors and chills are not very common, but exceptionally there can be some outliers. Otherwise, rigors and chills more favor infection. So this is one, the importance of identifying that symptom as rigor and chills as a pearl in the management of fever. Thank you very much, and we will finish this case.